Thank you all for joining us today. We'll wait a few minutes until more people are able to join us, and then we'll start this webinar. Thank you. Thank you for joining us. We'll just wait 2 more minutes before we get started. Thank you. Well, good morning, good afternoon, good evening, and welcome everyone to today's ICAP Grand Rounds. It gives me great pleasure to welcome you all today for our Grand Rounds that focus today on entitled In Search of the Silver Lining, where we will focus on the issues related to the impact of COVID-19 on the lives of older New Yorkers. Before we begin, I want to introduce myself. I am Wafa El-Sadr. I'm the Global Director for ICAP at Columbia University and a professor here at the Columbia Mailman School of Public Health. And we're thrilled to have with us today Dean Linda Fried, who's the Dean of the Mailman School of Public Health, to welcome you all to this webinar. Welcome, Dean Fried.
Thank you, Wafa, and welcome to everyone to this very important conversation in honor of the Silver Study of Older New Yorkers, which is a much needed and pathfinding study designed to better understand the mental health impact of the COVID-19 pandemic on older adults living at home. We're going to be focusing today and hearing about the experience of older New Yorkers in the community, but this is what we're going to be focusing on really is a generalizable to a global issue. Because of a century of investments in public health, in development, in education, we have actually created a demographic revolution where in the US, there are now as many people living long lives and alive over the age of 65 as there are children under 15. And globally, all countries of the world are similarly having the benefit of increasing the length of life. But in this pandemic, what we have discovered is that the shift in demographics has led to a very different picture of who's vulnerable than we saw 100 years ago in the pandemic of 1918. At a time when life expectancy was far less globally than 40. In the US, it was 47. And now it is in the US almost 80 and approaching that around the world. So one of the things we have learned is that while we have lengthened life, we have really not built the society to underpin these longer lives, which we could do, or to value what older adults bring, which is immense. But in the short term, what we've seen is that while most older adults have not gotten COVID, all have been impacted by the pandemic. And a year and a half into the pandemic, we know that COVID-19 mortality for older adults as one metric of that impact is profound. According to the US Centers for Disease Control and Prevention, 8 out of 10 people 65 and older report who died have been 65 and older, And over 75, there has been 7-fold the mortality for COVID compared with all other ages. A quarter of those deaths have been in nursing homes, although only 4% of US older adults live in nursing homes. So the 3/4 have actually been among older adults in the community. Many of these deaths have to do with the physiologic vulnerabilities associated with aging, as well as the increasing likelihoods of underlying disease, which we have learned leaves people vulnerable. But mortality only touches one part of the impacts of this pandemic on older adults. We have seen a rise in precarity, in worries about the ability to get food, about housing, about connection. And 28% of older adults are reported to have become lonelier in the pandemic, a consequence perhaps of our longstanding historic public health approach to isolation, which needs to evolve so that we don't put older people, particularly ever again in essentially solitary confinement in their homes for 18 months. But older adults, while our stereotypes are of precarity, of deficits, of decline, most older adults in our country and around the world bring immense assets that society can only gain from. Their roles and families are precious, but older adults represent the only increasing natural resource in the world at this time, bringing a huge amount of untapped and realized social capital that makes a difference in terms of the well-being and vibrancy of our collective lives and our communities. And yet the other thing that we've experienced in this pandemic is a huge rise and revealing of ageism, which has actually been called an invisible human rights crisis. The WHO, which is deeply concerned about ageism, loneliness, and social isolation in older adults, defines ageism as the stereotyping, prejudice, and discrimination against people on the basis of their age. It goes on to note that ageism is the most socially normalized of all forms of discrimination, unlike sexism and racism. Now, the phenomenon of ageism is neither new nor surprising. Older adults are stigmatized on the basis of their chronological age, and negative stereotypes are attached to the physical, cognitive, and emotional changes which occur with aging. And as a result of this ageism, there's widespread structural exclusion from opportunities, whether in education, employment, social services, even medical care and public health. And illnesses such as mental health conditions are often normalized erroneously as part of the aging process. These ageist stereotypes, prejudice, and discrimination happen to be internalized by all of us, but they're also internalized by older adults. This undermines, it's been shown, health, shortens life expectancy by 7 years, and undermines both optimism, self-esteem, and access barriers in the pathways to care and engagement. The COVID-19 pandemic, as with previous global health crises, from the bubonic plague to influenza, the world wars, and economic depressions, has acted to further normalize ageism, ironically. And it's ironic right now at the outset of the World Health Organization Decade for Healthy Aging, which runs from 2020 to 2030. The increased vulnerability of older adults to the pandemic, as well as their larger need for medical care resources, has been counterweighed against their perceived lower productivity and potential to contribute to society. Perceived, not actual. This perceived cost-benefit analysis has been reported led medical care to currently prioritize young and middle-aged adults over older adults. And the utilitarianism of perceiving lower value and productivity has led to an increase in the social acceptability of articulating ageist beliefs and prejudices, which has been seen throughout this pandemic around the world. But in the speeches of leaders and the comments of news media in some countries suggesting that the pandemic is even a means of culling people who are no longer competent. That's a presumption, not a fact generally. And and calling on older adults to stay at home and not burdened and overwhelmed medical care system, sacrificing themselves for the good of society. Hashtags such as boomer removal have been trending on social media platforms, implying that it is now acceptable to ask older adults to die. Now, hopefully these things are the exception, but the normative ageism has shaped many of our responses in the face of COVID, as complemented or exacerbated by our lack of preparation in general for an aging society. So I'll end by saying that we have a pandemic which has revealed a number of challenges for older adults and for all of us, and in particular, the ways in which our society has not actually embraced and adapted to the immense demographic revolution we have created of enabling people to live longer lives, and what we now know are the huge opportunities that they bring to all of us and to strengthening society. That is another conversation, but today I really welcome and appreciate all of the experts who are here to talk about what we have learned about the impact of COVID-19 on older adults living in our community and to set the stage for future solutions. Thank you.
Thank you very much, Dean Fried, for your insights today as we start this discussion today. I'm very pleased to first introduce the two speakers who will be presenting today, and then I will also introduce two additional individuals who will be joining us in a panel discussion after the talks. So our first speaker will be Dr. Jennifer Rosen, who is the Director of Epidemiology and Surveillance for the Bureau of Immunization at the New York City Department of Health and Mental Hygiene. And as part of the COVID-19 response here in the city, she has also served as Principal Scientific Advisor and Director of the Vaccine Confidence Branch. Welcome, Jennifer. Jennifer will be followed by Dr. Abigail Greenleaf, who will present thereafter. And Dr. Abba Greenleaf is public health demographer, who is a technical specialist at ICAP and an assistant professor at Columbia's Mailman School of Public Health. She has extensive experience in the design and conduct of phone surveys in the US and around the world, and she actually led the Silver survey that you'll hear about today. Now, during the panel discussion, we're going to be joined by two other individuals, and we welcome Catherine Thurnston, and Catherine is the Chief Program Officer at Service Program for Older People, SPOP, and in this role, she oversees the mental health clinic and the various satellites of SPOP that provide supportive services in New York City for older individuals. And last but not least, we are thrilled to also welcome Commissioner Lorraine Cortez Vasquez, and she's the Commissioner of New York City's Department for Aging, leading its mission to eliminate ageism, ensure the dignity and quality of life for older New Yorkers, and support caregivers. And she has previously worked at AARP and was president and CEO of the Hispanic Foundation. So without further ado, I will then hand over to our first speaker, Dr. Rosen. And I want to remind you to please, as the speakers deliver their presentations, please feel free to put your questions in the Q&A box, and so that we will then take your questions to the panel discussion after the presentations. I'll hand it over to Jennifer. Thank you.
Great, thanks so much for having me here today. Just share my slides. So today I'll be talking about COVID-19 in older adults. The risk for severe illness due to COVID increases with age, and older unvaccinated adults are at the highest risk for hospitalization and death due to COVID. It's really important that if symptoms develop for anyone, people should contact a provider and get tested away. But of note, for older adults, normal body temperatures can be lower than is seen for younger adults. So fever temperatures can also be lower. And so you want to have a lower threshold for seeking care and getting testing. Good news is that older adults with mild to moderate COVID illness are eligible for monoclonal antibody treatment regardless of their vaccination status. And early treatment can help to reduce symptoms and to reduce the risk of hospitalization. But because treatment needs to be initiated soon after the onset of symptoms, it's critical to test quickly and to call a provider and seek treatment right away. There's also post-exposure prophylaxis that's available for COVID, also with monoclonal antibodies. And certain groups of people are eligible for prophylaxis, including older adults who are exposed to somebody with COVID infection, who are either themselves not vaccinated or who may not respond as well to vaccination. So for example, people who are immunosuppressed, despite being vaccinated, may not have as much protection. So these groups would be potentially eligible for prophylaxis. Getting vaccinated is the most important way to prevent severe illness, hospitalization, and death due to COVID. In people aged 65 years and older who received 2 doses of Pfizer or Moderna vaccine, based on data from January through March, had a 94% reduced risk of COVID-related hospitalization. But it's important not just for people aged 65 years and older to get vaccinated, but also people who live with them, visit them, or provide care to older adults should also be fully vaccinated. This figure shows the number of confirmed and probable cases of COVID by day in New York City. And you can see right now that we are in our 3rd wave. And COVID remains elevated, and this is really driven by the highly contagious Delta variant. COVID has caused over 120,000 hospitalizations and over 33,000 deaths in New York City. And rates have varied by age, race, ethnicity, location, and vaccination status, which I'll now talk more about. This figure shows the number of COVID cases per 100,000 by age group in New York City, and just focusing in on our current 3rd wave. And rates of cases are lowest among older adults, as shown here. However, in contrast, rates of hospitalizations are highest among older adults, and you can see that the highest rates are seen in the 75-year and older age group. This figure shows the number of COVID deaths per 100,000 by age group. Again, this is just for the 3rd wave, and similar to hospitalization, to the hospitalization figure, rates of death are also highest among older adults, with the highest rates among those aged 75 years and older. This figure shows the vaccination status of older adults aged 65 years and older, and 80% of older adults have received at least 1 dose of COVID vaccine, with about 76% being fully vaccinated. This is a complicated table, but it's showing the percent of people who are vaccinated by age group, borough, and race ethnicity. So the darker blue colors reflect higher rates of vaccination, and the lighter colors reflect the lowest rates of vaccination. And the columns show citywide and by borough, and the different rows, the top section is for all age groups, and the bottom section is for people aged 65 years and older, broken out by race and ethnicity. And across all age groups, and for people aged 65 years and older, people who are Black have the lowest rates of vaccination. And looking across the boroughs, the lowest rates of vaccination are seen in Bronx, Brooklyn, and Staten Island, with higher rates in Manhattan and Queens. There have been many citywide initiatives to increase vaccine access for older adults, and some of the collaborations and initiatives that the Department of Health has worked on together with City Hall and many other groups are listed here. So in order to increase access to vaccination, we've supported transportation to support people getting to vaccine sites, which began at the start of the year. There were dedicated hours and priority appointments for older adults at the mass vaccine sites earlier in the vaccine rollout to make sure that this priority group really was able to get vaccinated, because early in vaccine rollout, as everyone recalls, there simply was not enough vaccine available for everyone who needed it. We helped to expand vaccination sites that were dedicated just to older adults. So for example, pop-up events, which began around February of this year. And a really important advance was initiating in-home vaccination beginning in March, which was really important for people who weren't as mobile, including many older adults, and also on-site vaccination in long-term care facilities began very early in December of 2021. So those, what I just spoke about, those were efforts to increase access to vaccine. There have been many efforts to increase vaccine confidence among older adults as well. And that includes vaccine promotion, education, and listening sessions in nursing homes and long-term care facilities, both not just for residents, but also for staff. There's been extensive outreach to medical providers to provide education on vaccine safety and to promote the in-home vaccination program for their patients. There were nurses who made calls to unvaccinated Medicare recipients to help coordinate in-home vaccination. And calls were also placed to older adults who did not have a COVID vaccine listed in the New York City immunization registry, specifically to adults who had other non-COVID vaccines in the registry, but no COVID vaccine. A mass mailing was done with educational materials for older adults, and thousands of presentations have been done to community-based organizations, religious institutions, and to community members. So thank you, and I will be happy to take questions during the question session.
Thank you very much, and we'll hand it over to Ava. Welcome.
Thanks, Wafa, and I'm thrilled today to share results from the Silver study that I worked on with Dr. El-Sadr and others here at ICAP. In terms of a background, Dean Freed and Dr. Rosen have made my job quite easy, giving a clear background of what has taken place among older adults during COVID. So I will note that compared to the all age mortality in New York City, the mortality rate for those over 70 from COVID was 7 times larger. Knowledge gaps persist about the secondary health impacts of COVID on older adults living at home, and that's what this study aimed to do. In other words, most of the data and research on older adults and COVID-19 is from congregate care settings, so we felt that there was an important need to address community dwelling adults. Therefore, to fill this gap and to understand the social impact of COVID-19, we conducted a phone survey called the SARS-CoV-2 Impact on the Lives and Views of Elderly Residents, which spells Silver, to learn more about those age 70 and older. There's about 1.1 million New Yorkers over 70 in the city. So just briefly, I'll go over the methods for the study. Because we were focusing on adults 70 and older, we decided that a landline phone survey using live interviewers would be the most representative, cost-efficient, and safe data collection approach. During the design phase of the study a year ago, we oversampled in neighborhoods with high COVID-19 burden to ensure that we captured the experience of the most vulnerable older New Yorkers. This meant our sample had 5 strata, 1 per borough, and an additional 6 sampling strata that included 18 zip codes with the highest COVID case count as of October 2020. The interviewers called a random sample of New York City landline phone numbers, and if someone answered the call, The interviewer asked if there was a household member over the age of 70. If yes, the interviewer attempted to enroll the individual through an abbreviated informed consent process. To note, if there was more than one individual over 70 in the household, the individual with the most recent birthday was chosen for the survey. In other words, we had one respondent per household. We offered the survey in 5 languages: English, Spanish, Haitian Creole, Mandarin, and Cantonese. At the end of the survey, participants were offered a $10 electronic gift card or check in the mail. They were also asked to consent for future research. So I want to show this slide because it details the sampling and response process for a random digit dial survey. I think sometimes people can be shocked by a response rate, but when you see the steps of how you get to respondents in a random digit dial, it makes sense why the response rates are so low. So it's really a labor-intensive process to do a random digit dial survey. The interviewers called 48,759 phone numbers. 47% of those calls were not picked up, and you can see on the slide why they were not in the red box. So among the 53% of calls that were answered, the vast majority of numbers, 96%, didn't have an eligible respondent, or there wasn't a residence, or the interviewer wasn't able to have a long enough conversation to establish household member eligibility. So ultimately, among households with eligible respondents, 71% participated in the survey, meaning we had 676 participants enroll with a 5% response rate, a response rate that's on par with other landline phone surveys. So here I reshare the epidemic curve that Dr. Rosen showed earlier to help you place what was happening in New York City during data collection for silver. We collected data from early December 2020 to the end of March of 2021. And as you can see, it's during the second wave of COVID in the city. We began silver before vaccine distribution began. Specifically, those 75 and older living at home were eligible for the vaccine as of January 11th, 2021. There were 73 survey questions, and the broad categories are listed on the slide. As I work through the results, you'll get a better idea of what each category included. Just to note, the survey took about a third longer than we had expected because participants were eager to speak to someone and share their experience. So I'll now share the results of the survey. All results were weighted to account for survey design, eligibility, non-response rates, and post-stratification. I'll note any socio-demographic distributions that don't match the city's older adult population, but in general, we were quite pleased with how our survey represented the city. Survey participants were 60% men and women and 40% men. Almost 2/3 of the sample, 62% were adults aged 70 to 79, and 38% were over age 80. 44% were married, and 66% were not currently or were never married. 16% of older adults had no pre-existing health condition, 21% had only one pre-existing health condition, and the vast majority, 63%, had 2 or more pre-existing health conditions. Not shown on the slide, but to note, 90% of participants reported not currently being employed. So the majority of respondents lived in Queens or Brooklyn. Just about 1 in 5 of respondents live in Manhattan, 14% in the Bronx, and just 7% in Staten Island. The racial and ethnic distribution of participants reflects the city, except that unfortunately Asian participants were underrepresented. So the 14% of those who identify in another way include Asian Americans, a group that proved to be difficult to reach during this landline survey. Another note is that about half of the survey sample was born outside of the US, which is reflective of the rich diversity of New York City. So although the focus of the survey was the secondary impact of COVID-19 as Dean Freed, most older adults did not get COVID, but everyone has been impacted by it. So we focus on the secondary impact, but we would be remiss not to ask about quarantine, isolation, testing, and illness. So when we asked participants if they'd ever had to stay at home, 14% yes, with almost twice as many of those 70 to 79 having quarantine compared to those over 80. 63% of older adults had ever tested for COVID, with again, more of those 70 to 79 ever being tested. And of those tested, 12% had a positive test. We wanted to understand the impact of others' illness and death from COVID on our participants. So we asked participants whether they knew anyone who had tested positive. You can see 63%, most older adults knew at least one person who had had COVID. And looking at the pie chart on the right, 50% knew someone who had died from the virus. So moving to vaccines, in December, at the beginning of the survey, we had to ask participants a hypothetical question as the vaccine was not available. So we asked participants, how likely are you to get the COVID-19 vaccine once it is available? Then, beginning in February, we began asking participants, have you received the COVID-19 vaccine? And those who hadn't received the vaccine, we asked how likely they were to get it. We found that 60% of participants had received the vaccine, and interestingly, more men than women had received the vaccine, 70% of men reporting compared to only 50% of women. So this chart shows how likely an unvaccinated participant was to get the vaccine. The majority, 90% of participants, reported being very likely or somewhat likely to get vaccinated. The remaining 10% were somewhat or very unlikely to get the vax. Mirroring the trend of more men than women being vaccinated, a greater percentage of men, 82%, reported they were very likely to get the vaccine compared to 73% of women. And although overall likelihood of getting the vaccine was high, likelihood did differ by race and ethnicity. As you can see on the slide, white participants were most likely to report being very likely compared to 42% of Black participants, 67% of Black participants being very likely. Before I move on from vaccines, I will note that we also asked about the flu vaccine, and 60% of respondents said they had received it. So the ramifications of the COVID-19 vaccine on mental health are well documented, but we felt we could add to the literature by asking older urban adults about their mental health. So we found overall 18% of participants screened for depression and 17% for anxiety. This is double the 2017 New York City Community Health Survey depression rate, which was 9% among older adults. And to note, the overall rate of depression and anxiety were higher than some national numbers I've seen, but those surveys took place at different times. So it's hard to say if it was the current context or being a city or another cause. Looking at trends by race and ethnicity, we see that Latinx participants were the most likely to screen positive for depression and anxiety. And among Silver participants, more than 2/3 reported interacting a lot less with people since COVID had started. One of the clearest correlations with mental health was income. So you can see that reports of depression and anxiety were higher among those who made less than $25,000 annually, with 23% screening for depression and 21% screening for anxiety, compared to only 5% of those who make more than $100,000 a year screening for depression and 6% for anxiety. All to say, income is a clear social determinant of mental health among older New Yorkers. A few more mental health outcomes by key demographics, namely immigration status. Rates were similar among those born in the US versus those not born in the US. Employment, those who were not working had almost 4 times the rate of anxiety and depression compared to those who were working. And unsurprisingly, previous diagnosis of depression or anxiety was indicative of current depressive symptoms. So given the uniquely tight living quarters in New York City, we were interested in who older adults were living with. And most frequently, older adults lived on their own, 43%, or with another person, 39%, with the remaining 19% living with 2 or more people. Just over 1/3 of participants were in multi-generational households, with almost twice as many women than men living in a multi-generational household. Unsurprisingly, COVID-19 positivity in multi-generational households was double that of households that were not multi-generational. So to understand the impact of COVID-19 on social determinants of health, we asked participants about material circumstances. Starting broadly at the top of the graph, we see that almost 2/3 of older New Yorkers reported that COVID impacted their lives in a negative way, somewhat or a lot. And then we see just under 1/3 had financial problems, Just under a third reported receiving food from a food pantry, community organization, or the government, and that about 1 in 10 did not have enough to eat. Verbal and physical violence were rarely reported. So given the dependence on phone and internet for communication while isolating at home, we were eager to understand how older adults were connected. We found that overall, 22% of participant households do not own or use computers, smartphones, or tablets, and 30% of those 80 and older do not own or use an electronic device. A quarter of women did not have a computer, smartphone, or tablet, which was more than men. On the right side of the slide, you see that 78% of older adults had some type of technology, whether a phone, computer, or tablet, smartphone, computer, or tablet. And just quickly, about 44%, under half, reported a telehealth appointment in the last 3 months. So given that 1 in 5 older adults didn't have internet and 43% of participants reported living alone, we were glad to find that nonetheless, 9 out of 10 older adults had someone to talk to. Family members and spouses were the most likely to provide emotional support as well as assistance with tasks. Participants did not report great use of phone-based city resources. Starting at the bottom of the slide, helplines in New York City services for telehealth visits were not widely used, but neither was support from faith-based organizations or housing assistance. However, local or city food pantries were well used. This brings me to the conclusions of the Silver study, and I hope that these conclusions will speak to what Dean Fried mentioned at the beginning of the webinar about the need to create a society that supports those now that we are living longer lives. So starting with the first bullet, while the majority of older adults indicated an intention to be vaccinated, vaccination rates and intentions were lowest among Black participants, mirroring a nationwide trend of hesitancy among Black Americans, a group whose medical experience is one of institutionalized racism. So understanding that historical context, I think, can help work in that area. Of course, our findings add to the literature about the importance of social determinants of health. And as you know, we focused on mental health in particular. I was really interested to see that a substantial percent of older adults did not have internet or related technology in their home. Again, that means 1 in 5 older New Yorkers were not able to connect to others via internet during the pandemic. You know, this limits access to telehealth services, information sources, and required them to use the phone line for vaccine appointments. I'll note that Latinx participants were most likely to report someone who had died of COVID-19, who were more likely than any other race or ethnicity to have tested themselves for COVID, and were also the most likely to test positive for COVID-19. Consequently, a greater percentage of Latinx older adults screened likely for anxiety and depression and reported more loneliness than other races or ethnicities. You know, we hope that these findings will contribute to future policies and programs. We're eager to continue research on silver, and we'd very much like to acknowledge the funders for this study, New York Community Trust, Samuels Foundation, and an anonymous donor. Thank you.
Thank you very much, Abba, for summarizing just a little bit of the rich data from the Silver study. I'm going to now invite all of our panelists to maybe show their videos so that we can start our conversation. So let me get started with you, Catherine, regarding in terms of what you heard from the results, at least the early results, these preliminary results from the Silver study. How do you think you can use these findings in your work and the work of your organization?
Thank you, Wafa. Absolutely. I think when Ava first shared the preliminary results, what we saw was a validation of what our clients and participants were bringing to us, which were greater rates of depression and anxiety. But also one of the most, I think, strongest points in the study that really impacts the work that SPOP does as a community mental health provider is that so many older adults are disconnected from the ability to be engaged in telehealth, engaged in care, because they don't have access to Wi-Fi or a computer, or even if they do, they're not fluent enough to be able to or their technical literacy is such that they're not able to participate in an ongoing way. And as an advocacy organization as well, I think the message is that behavioral health services that have been delivered over the telephone for the last 18 months have actually been extremely successful. And we have been advocating with the Centers for Medicare and Medicaid Services to continue to allow telehealth behavioral support, because we will not be able to provide every older New Yorker with access, at any point, even though as Dean Fried, very wisely pointed out, our infrastructure does not match the needs of older adults, but being able to provide these services in a variety of different ways, including the telephone, is one that we will need to continue as isolation is not only a result of this pandemic, that older adults live in, these situations all the time. So I think that the study has really sort of buttressed that for us and has been very helpful in shining a light on that.
Thank you very much. And maybe I'll move over to ask Commissioner Cortez Vasquez to build on your your response, Catherine, and in terms of what the ways in which the Department of Aging is trying to address the issue of that we saw in the silver results, the issues around anxiety, depression, isolation, and so on.
Well, thank you. Well, it's great to see you. It was wonderful to hear the presentation after reading it. So thank you for allowing us to participate in this. Social isolation has been a concern for the Department of the Aging pre-pandemic, because it's we know the impact that social isolation has on health for older adults. So we've always been engaged in many ways to combat social isolation. But what we noticed during this pandemic, that the anxiety levels increased tremendously. So in addition to, DFDA has always had a friendly visiting program in place. And we also had a geriatric mental health program where clinicians could go from site to site. And we had 48 centers engaged in this kind of programming. And we also found that 54% of those treated achieved a reduction in depression within 3 months. And so we were, based on this success and also based on the concerns that were rising as a result of the pandemic, we were able to extend that program more than double its size currently, and we're really proud of that. And we also noticed, which means that we will have almost 88 programs involved in geriatric mental health throughout the city of New York in languages and cultures that reflect the population, which is also very important to us. One of the other things that we're doing is we've expanded our friendly visiting program. And of course, during the pandemic, friendly visiting had to take on a new form, and it was called Friendly Voices. And as a result of that, we've also said that 52% there's significant reduction in social isolation of those who participated in the friendly visiting and the Friendly Voices program. And we have also conducted daily, we have a network of agencies who are the partners who deliver these services to individuals, again, in their home, in their communities, in their language, in their culture. And so we instituted wellness contacts during this pandemic, and over 5 million contacts have been made to over 200,000 clients. And it was a way of making sure that they stayed connected, and also gave us able to link them to other services that they needed. So it was taking that basic information that we have and expanding it and really building on that experience. So I really think that we've come a long way, and yet I agree with you. One of our biggest challenges, and I can talk about that later, has been around technology, and I can give you some how we address some of that.
Well, thank you very much. It's very impressive to hear of all the innovations that COVID has necessitated, and I think it will be interesting to think about what we're going to keep and what we're going to let go of as hopefully we move beyond COVID. I have a question for you, Dr. Rosen. You showed data that highlight the disparity that exists in terms of vaccine uptake between older Black New Yorkers and others. And I'm just wondering, and this reflects overall the findings in the city overall. I'm just wondering from your perspective, what are ways in which you are, first of all, what do you think are the reasons for this? And what are some interventions that you're thinking about to overcome this disparity?
Yeah, it's a great question. And at the individual level, there are many different reasons why people might not feel confident in the vaccine. And that can vary person to person across and within race and ethnic groups. But certainly one important issue is mistrust among Black New Yorkers is mistrust in the healthcare system due to historical and ongoing racism that people have faced. So that's certainly a big issue. And in terms of ways that the city is trying to address gaps in vaccination coverage, there are priority neighborhoods where rates of vaccination are lower and that have other social and health inequities that have been a real focus for vaccination outreach, both in terms of ensuring extensive access to vaccination, but also engagement with community-based organizations and faith-based organizations, doing a lot of presentations to the community, but not just having the health department do the presentations, but rather train the trainers so that we can train community and faith-based organizations so that they can work with their own communities and serve as trusted leaders and trusted messengers, and having listening sessions. So the focus is not just on lecturing people, but really listening to people's underlying concerns. You're never going to get people vaccinated if you don't understand what their concerns are and really address their concerns and questions.
Yeah, it's interesting that probably maybe what you're learning, Catherine, from your network through SPOP in terms of what you're hearing could also be very useful in informing the activities both from the Department of Health and the Department of Aging as well. Kind of a two-way street to be listening and then obviously shaping the responses based on the inputs that you're hearing. I'll move on to you, Ava, with a question that one of our audience put in the Q&A, and I encourage others to please put your questions in the Q&A box. And that's related to what are the types of comorbidities that were reported most commonly. And maybe you can touch on some of the other analyses that you're thinking about in terms of digging deeper into the silver data.
Thanks, Wafa. And yeah, I'm really excited to do more analyses with the data. I don't have off the top of my head the most frequent pre-existing conditions, but that's certainly something that's not hard for us to look into. I think there was also a question in the chat about correlation between prevalence of depression or anxiety and family size. We are working on a multivariable analysis of depression and anxiety, looking at what is correlated with that. So that's one of the first papers we want to get out, is I think understanding risk factors for depression and anxiety among this population is important. As Commissioner Cortez Vasquez noted in the different programming, there's a lot going on, and so we hope that information will be helpful. We're also really excited about the telehealth data and are working on analyzing that more closely. I was really shocked to see that 1 in 3 older New Yorkers over 80 didn't have internet at home. So figuring out what that population looks like and who they are, I think, can always be helpful. The third analysis that I'm particularly excited about is looking at the experience of COVID by immigration status. As I mentioned, the sample does reflect the rich diversity of New York, with 50% of our sample reporting not being born in the US. So I think that will be a really important aspect to look at. So those are kind of the analyses we have brewing.
Thank you very much. I'll go back to you, Commissioner Cortez Vasquez. And a question from the audience is one individual who indicates they're a member of a senior center and was asking the question about, I guess, the current limited hours of the centers and as well as limited meals may have impacted utilization and the impact of these centers. So, question is, when do you anticipate, usual services to be reinstated for this very needy population?
That is a question that I get every day. We had March 2020, we had an executive order and we shut down programs. And we shut programs down to June 14, 2021. So that was over the span of a year. And reopening centers is not, you don't just turn on a light switch. There is, you have to look at physical plant. And we are also still in this third phase and nowhere near the end of this pandemic. And so services will be limited, as with many things. Given what we've already heard with this study, with the amount of people who are still unvaccinated, who are over the age of 60, we have to take the highest precautions. And so given the fact that we are not at this time asking about vaccination status or even asking for proof of vaccinations, we have limited capacity to 25% for any indoor activities. And we've also all the social distancing requirements. And so programs are being as innovative as they possibly can with their own staffing concerns and limitations. And they are, ranging multiple seatings so that we can have food. Programming is somewhat limited. If programming, fortunately, the weather is still allowing that we can have programming outside. But I do not see, unless we see a dramatic change in vaccination. And I think that we're working towards recovery, but I cannot foresee the day. I thought that was going to be July 2020, and then July 2021 passed. So I can no longer predict or even foresee when we will have normalcy at older adult clubs. We are working very closely with the Department of Health every day to monitor the conditions and the degree of vaccination among older adults. And so as we see that increase, we will work with the Department of Health to ease some of the limitations. But, it takes 90% of a community to be vaccinated before you have somewhat of a sense of normalcy. We're nowhere near that.
Yeah, that's, thank you very much. And that highlights how everything is interconnected in many ways. And I think one of the things that Abba and I have been talking about is the fact that it would be incredibly useful to repeat the Silver survey. We do have many of the participants indicated they're quite willing to be recontacted again. And it would be interesting in this random sample of the city to get a sense of now what is the vaccination uptake, because that could help you in advocating for more reopening or a higher capacity for the senior centers and so on.
Right.
And so Abba, can you talk a bit more about, was there enthusiasm or interest by the participants to participate again in other surveys?
Yeah, thanks for asking. Almost 90% agreed to be contacted for future research. So we found that the population was happy to be involved, and we think that this is a really interesting cohort that we've created, and we are looking to follow them over time to look at, as you just mentioned, changes in vaccination status, determinants of mental health, and looking at how their social determinants of health has changed so that we can continue to feed this data back to partners and different city agencies. So I think there's a lot of potential to use this as a baseline and track and improve for older adults in New York City.
Great. And going back to you, Dr. Rosen, is that you mentioned, of course, the focus on communities and getting vaccines, as we say, get the vaccines to the people rather than asking the people to come to the vaccines. You know, in some ways, you know, New York is such a diverse community with many, many different languages. I mean, our survey only, of course, covered several languages, but not all. And how are you diversifying or thinking about diversifying the workforce, for example, to be able to, we've seen that with the contact tracing program and the need to diversify the workforce to be able to reach the different communities. And are you thinking of diversifying in terms of ages of the workforce also to reach others, to reach their peers?
That's a really great question. So, you know, things that the agency and the city overall does is making sure in terms of language, for example, making sure that all materials are translated into the commonly spoke languages. You know, one really important point that you touch on is the importance of trust. So in terms of people that are relaying information, you want them to be trusted messengers, trusted leaders from the community, trusted community members. And so I think one of the important strategies is working with community-based organizations and faith-based organizations. So rather than having the health department come in and tell people that they should get vaccinated, identifying these trusted leaders from within the community and trusted community members so that people from within the community are giving the education, they're giving the messages. People often feel more comfortable listening to people who are more like them. And so working together with the communities is really critical.
Right. And then maybe from your perspective, Catherine Thurston, and you're in a community-based organizations, is, you know, looking at the array of individuals here on the screen, and how do you see it from a community-based organization, your perspectives and how to work effectively or most effectively with some of the city agencies in particular?
That's a great question. So, you know, we are funded by both the City Department of Health and Mental Hygiene and the State Office of Mental Health. So we have many overlords, and we deal pretty regularly. And we also are funded, of course, by the Department for the Aging. As the commissioner noted, we are one of the Thrive NYC sites that have provided mental health in senior centers or older adult centers for many years prior to even the DIFTA initiative. But we are constantly updating our clients and our participants about regulatory changes. We just had our first virtual town hall meeting we have about 1,000 clients at SPOP. We had a virtual town hall meeting that was both telephonic and Zoom to give people updates. But I wanted to speak a little bit to the vaccination point, because 88% of our clients are vaccinated, and we are very proud of that. Again, we are a behavioral health organization. We're not a federally qualified health center. We can't vaccinate on site, but we were encouraging our clients to be vaccinated. And one of the things that we learned, absolutely to echo Dr. Rosen, people listen to their community members, their faith leaders, but we also learned we operate a day program for severely and persistently mentally ill older adults, a PROS program, the only geriatric PROS program in the state of New York. And we had lower vaccination rates in our PROS program. Many of those participants had lived for decades in the state psychiatric facilities and were very leery of vaccinations. And what was the most positive thing that we discovered was that when one community member got vaccinated and talked about it with other community members, without staff present, without staff involvement, it was listening to your peers and having peer-to-peer support was a very positive correlation to vaccine status. So again, that's hard when you're not congregating together, but even telephonic groups or Zoom groups for older adults can really lead, I think, to some good positive change.
It's very interesting, and it highlights how, like I was saying, there are important lessons that we're learning, both that demonstrate the gaps that exist in the community, but also the opportunities to address some of those gaps as well. Unfortunately, we have reached our hour, and we have so many more questions. But I do hope that this was a beginning of a partnership and hopefully a collaboration to try to fill some of these gaps and see some improvements in some of these metrics that we shared with you today, whether they be in terms of vaccination uptake or some of the mental health metrics that Ava shared, and the concerns about the financial and food insecurity in particular that we didn't have time to dig in deeply. And we certainly are seeking and eager to identify the resources to be able to do the survey again and to bring more data back to you again. So I want to end by thanking all of you for being with us today, your participation, your commitment to this work. I want to thank all of our audience who joined us today on this very important webinar. And I want to invite you to the next ICAP webinar, which is scheduled for October 19th, and it's entitled Protecting Health Workers in the COVID Era. So please put that on your schedule and plan to join us again on October 19th. Thank you very much and have a good day, everyone.